In this lecture, we will be discussing ventricular dysrhythmias. The objectives is identify the EKG characteristics of dysrhythmias that originate in the ventricles, describe the hemodynamic consequences of selected ventricular dysrhythmias, describe the clinical management of patients with ventricular dysrhythmias, and describe the clinical management of patient with asystole or pulseless electrical activity, known as PEA. First thing we're going to talk about is a bundle branch block. You'll probably be taught more advanced information about the bundle branch block. We're not going to be able to determine whether it's a left or right bundle branch block. That's not significant because you would need to have a 12-lead EKG to determine if it's right or left. But the presence of a bundle branch block is usually determined by a wide QRS, and it looks different, or a bizarre complex in a single monitoring lead. So looking at the different types of bundle branch blocks, they tend, again, your QRS is wide. You do have a sinus P with before the QRS, and the PR usually is normal, but the only difference is that your QRS is greater than 0.10. And now you're looking at this QRS, again, it looks like about 3 boxes. And again, you can't really determine this, even like 3.5 boxes, even in some of them, maybe. So you can't determine whether it's a right or left bundle in one lead. And in the bottom, again, you're looking, I know it has these rabbit ears, but that does not mean, it depends on what lead it is, as to determine whether it's right or left. And that would be by a 12-lead EKG. And you can see in this top rhythm, that the R to R is regular. The heart rate is about 60-ish, 70. Let's see, 1, 2, 3, 4, 5, 6. I think it's 65 or so. You have sinus P waves before every QRS. The QRS is 4 boxes or so, or 3 to 4 boxes. Your PRI is normal, about 0.16, 4 boxes. And again, it's a bundle branch block. And on the bottom one is 9.3, and that heart rate is 68. Your PR interval, it looks like about 5 boxes. And your QRS is wide, it's about 3 to 3.5 boxes. And just because that's a notched QRS, but it is common to see in a bundle branch block, a notched QRS. But again, depends on what lead it is. You may see somebody that has a bundle branch block that is an atrial fib. And just remember, when you have a bundle branch block, what you're looking at is you have your heart. I'm going to just draw your heart. It comes somewhere from the atrium. And normally any rhythm that comes from the atrium will create a normal QRS. Because it starts in the atrium, it will go down the bundles of His. But if you have a blocked bundle, so if you have like a right bundle block due to some surgery or something, that impulse is, this one's coming from AFib, so it's being bombarded, but it's still coming from the atrium. It's going down and it gets blocked and it can't go down the right, so it's going to go down to the left bundle, but it'll go cell to cell to cell to cell to get to the right myocardium of the right ventricle. So therefore it takes longer, and that's why you have a wide QRS, because it's taking so long for the depolarization of the ventricles, because you don't have the fast bundle to go down because it's blocked. Now we're going to talk about ventricular dysrhythmias that come from the ventricle. Usually ventricular dysrhythmias require prompt recognition, and many of them are life-threatening and require immediate interventions. But fortunately, they are easy to identify, and you should be able to identify these by sight. You shouldn't have to be measuring anything. You should just be able to see them and pick them out very quickly. So again, we talked about the depolarization. Normally, the flow of electricity will come through the heart from the top, and it's work its way down to the bottom. Now, it will produce a positive deflection because it's coming from a negative and going to a positive. That's the normal conduction. However, this impulse is coming from somewhere in the ventricles. And if it does, what happens is it's going in the opposite direction through the ventricles, but it does not go to the atrium. It does not go back up into the atrium. It's just basically going from one side to the other, and it takes time, so it's going to be wide because does not go back up and go down the bundles of hits at the same time. So again, if you have it, the impulse is coming away from the towards the positive, it's going to give you a positive deflection. Away from the positive, it's going to give you a negative deflection. And again, it takes longer for those QRSs, because the depolarization of those ventricles, because it is not going down the bundles of His at the same time, giving you that normal QRS. And also, usually if it comes from the ventricle, you're going to see a T wave in the opposite direction of your QRS. So ventricular beats are wide, bizarre QRS complexes with a significant voltage height. You have large T waves that go in the opposite direction of your QRSs. There is no P due to no retrograde conduction to the atria. Again, your cardiac output comes from your ventricles, so they're not going to go back up into the atrium. That conduction is meant to give the optimal amount of cardiac output, so it's going to depolarize your ventricles and hope for some kind of contraction. So we talked about premature beats, we talked about PAC, we talked about PJC. Both the PAC and PJC come from the atria. A PVC is a premature ventricular contraction, and that comes from the ventricle. And again, it comes early. So when you're looking at your premature beats, it is a beat that comes early. And then looking at the premature beat, is it normal or is it wide? In this picture, you can see that this QRS is wider than the other QRSs, and there is no P, because this T wave is the same height as all the other T waves, so there's no P hiding in there. So this is a premature beat, it's wide, and we consider this a PVC. And it usually will have a compensatory pause, meaning that the QRS was supposed to come in here, and it would come right back where it left off. Sometimes you will have patterns with your PVCs, and this would just be a way to describe how often they're having PVCs. For an example, in this pattern, it is a ventricular bigeminy, meaning every other beat. So there's PVCs, they're premature, and they're every other beat. In ventricular trigeminy means that every third beat you have PVCs. And again, ventricular quadrageminy means that you have PVCs every fourth beat. I also want to point out, when you look at the PVCs, do they look the same? Do they have basically the same shape? In these two PVCs, there is the QRS is going up and your T wave is down. Again, just to remind you, usually with PVCs, your T waves go in the opposite direction of the QRS. And looking at these, they both look the same. That would make them come from the same spot in the ventricles. So somewhere in the ventricles is firing, or an increase in automaticity, and it's causing them to look the same because they came from the same focal point, or unifocal, one focal point. So we call them unifocal. When there's more than one PVCs and they look the same, we call them unifocal. Same as if there's coupling. So there's two PVCs in a row, They look the same. They're unifocal. If you have 3 ventricular beats in a row at a rate of 100 or greater, then we will call that a run of VTach, or ventricular tachycardia. We can call this a short burst of VTach. If you have more than 1 PVCs and they look different, so if you can see in this one, it has the positive deflected QRS and a negative deflected T wave. In this one, you have a negative deflected QRS and a positive deflected T wave. So these two look different. So multifocal PVCs, sometimes called multiform, or PVCs with different morphology or shape, the different shapes or deflections indicate that the beats are originating from different sites in the ventricle, thus indicating more widespread area of increased automaticity and a greater risk for VTach or V-fib. So multifocal PVCs are worse than just having unifocal PVCs, where they would just be coming from one spot in the ventricles that is increased automaticity. We talked a little bit on the first lecture on R on T phenomenon. So PVCs, which occur during the vulnerable period or the relative refractory period of the ventricular repolarization, whereas in the peak to the end of the T wave downslope, stimulation during this time can result in recurrent PVCs and can progress to VTach or V-fib. It's more likely to occur when your QT interval is prolonged, and this is the cause of sudden out-of-hospital cardiac arrest due to acute MI. So narrowed coronary arteries cause decrease in blood supply and oxygen to the cardiac cell, and this can cause increased ectopic sites that pop up, and again, in a high risk for R on T, and it basically causes a reentry. So when you see a PVC, note where it comes in the T wave. So those are much more dangerous and has a higher incidence of patients can develop VTach or V-fib. And again, it's coming right in the middle of that T wave where it starts. Your causes of your PVCs, most common is coronary artery disease in the elderly patient. But it's important to determine the cause because initiating antiarrhythmic drugs is a little benefit if the underlying problem is uncorrected, such as hypoxia or electrolyte imbalance. So rule out the cause. And does the patient have pain? Is the O2 sat okay? Have they been adequately medicated for anxiety, drug history? So these are all things that you should check before starting them on some kind of medication. If they are getting a lot of PVCs, they may be encouraged to take out caffeine or cut down on alcohol or stop smoking. Sometimes stress in life can cause PVCs. I know I had unifocal PVCs, and I didn't realize it until I was hooking myself up to a monitor to check a printer instead of using a simulator, and I noticed I was having PVCs and Bigeminy at times. And because there was a lot of stress in my life at that time with a death in the family and some other things going on, going to see the cardiologist, and they said it was probably due to the adrenaline levels and the cortisol levels that increase during stressful times and can produce PVCs. I had to wear a Holter monitor, I had a stress test, everything else was absolutely normal, but stress can cause that increased automaticity and trigger PVCs. So it's a matter of trying to get relaxation and decrease the stress. Oftentimes you'll see patients with myocardial ischemia or infarction, again having those PVCs, and monitoring what medications they're on that they might be having PVCs, such as DIG or some of their tricyclic antidepressants, aminophylline, or epinephrine containing decongestants can increase the heart rate and automaticity. The clinical significances may be a precursor for more serious ventricular dysrhythmias. So again, identifying why they're having the PVCs and then following up with a cardiologist, maybe having a Holter monitor to find out how often they're having PVCs. In my Holter monitor, I can't remember how many, he said I think maybe 5,000 in a 24-hour period, but he said he wasn't concerned unless it was well over 10,000. So, and gave me the option if I wanted to go on a beta blocker to suppress them, but I chose not to, and just decreased my stress. Other causes, so electrolyte disturbances, especially potassium and magnesium. So hypomagnesemia and hypokalemia can cause PVCs to occur. Again, we talked about the MI and CHF and a cardiomyopathy. So anytime you change in the dynamics of the cardiac muscle, it can pop up ectopic sites, such as an enlarged left ventricular hypertrophy, or valve disease that causing hypertension. That can change the structure of the left ventricle, and it can also increase the automaticity within the muscle and fire more PVCs. Other things that can do it is insertion of any catheter into the ventricle, such as if they are putting a triple lumen or central line, and if the guide wire tickles the right ventricle, then what can happen is it irritates that ventricle and it can start PVCs. Once you remove the guide wire or the catheter, then the PVCs go away. Other things that can cause PVCs is reperfusion dysrhythmias, and this is a good thing because after a patient has had an MI and you give them reperfusion therapy such as a TNK or thrombolytic, or if you've gone to the cath lab and they've been reperfused, sometimes that reperfusion will cause PVCs, and that's just all of a sudden the myocardium's getting a reperfusion, and it can cause an increase in automaticity, and the patient's heart can throw out some PVCs, but that usually will stop, and it usually is indicated that, oh, we have good perfusion now. The management of these patients with PVCs is, again, correcting the contributing circumstances. An antiarrhythmic may be needed if no reversible cause is found. So how is the patient presenting? They may not require any treatment. So it's significant PVCs requiring intervention, usually such as an antiarrhythmic medication, is when you have more than 6 per minute, or if they're multifocal, or if they're having R on T, or pairs or runs of 3 or more. Those are the ones that probably would need an antiarrhythmic. So ventricle escape beats are ventricular beats which occur late, because it's opposite of the premature or PVC. These come late, and their significant is that they occur when both the SA node and the junction have failed to provide adequate heart rate. So it's likely to occur under the influence of a vagal stimulation or the presence of SA-AV node ischemia, such as in an inferior wall MI. In and of themselves, they require no treatment. If they are present along with significant bradycardia, then the patient would be managed using the bradycardia treatment algorithm. But again, if you had a premature beat, this PVC or ventricular escape beat would be early. It is not. If you measure between your R to R's, you would probably have an R to R right here, and it didn't fire, so you have a ventricular escape beat that kicked in because your SA node and your AV and your junction failed. So this is kind of like a backup pacemaker that kicked in, and then your patient's own SA node fired in and came in. And again, it's usually due during a bradycardia where it slows down to less than 40, and therefore your ventricular escape beat will kick in. So an idioventricular rhythm is basically like an idioventricular escape rhythm. You may hear terminology. That means that your SA node has failed, your junction has failed, and now your ventricles have taken over as the primary pacemaker. It usually is regular. The rate is 40 or less. There's no P waves because it does not go back up into the atrium, so there's no PRI to measure. And because it originates in the ventricles, it does not go down the bundles of His at the same time, so therefore it goes cell to cell to cell to cell from where it originated, and it moves through the ventricular myocardium in that fashion instead of down the bundles of His, which would give you a normal QRS from the atrium. So the QRSs are wide, usually greater than, equal to, or greater than 0.12. Oftentimes the QT would be normal for the heart rate because it's going to be a slow heart rate. And sometimes you'll see this called the idioventricular escape rhythm. Or you may hear it be called IVR. So when your primary pacemaker of the SA node and the secondary pacemaker at the junction fail, or the impulses fail to reach the ventricles, the pacemaker cells in the ventricles take over the pacemaker function at an inherent rate of usually 40 or less. So with this, you're going to measure your R to Rs, which you don't have. You have QSs to QSs, and that's okay. You can measure from here to here, and you count how many boxes you have. This looks like 37, and I believe that gives you a heart rate about 41. So you can also check your 6 seconds. If you wanted to check your 6 seconds, you would not count that one. So there's only 4 complexes between your 6 seconds, and therefore you would have a heart rate about 40. And more exact is 41. And as you can see, there's no P wave. It's regular, and it's very wide. And a lot of people are like, well, how do you measure your QRS? Well, you can see that it's very wide. We don't worry too much about measuring your QRSs, even though we were asking you to do it, but in the real world, we can see that it's wide. We're more concerned about what the patient's doing, because when the heart rate's this slow, you have no atrial conduction, you've already lost your atrial kick, and going this slow, you probably have a symptomatic patient. Your causes are usually associated with significant heart disease, and it often is a transient or terminal rhythm immediately preceding asystole. Because it's almost like a dying heart. The heart, again, your SA node failed, your junction failed, so the last resort of it is a pacemaker, and it's so weak and it's very slow, you probably barely have a pulse, if any, and it's going to be basically what you call a dying heart, or agonal rhythm sometimes. It's dramatically reduced cardiac output because of that loss of that atrial kick and poor muscle contraction. And you don't have the synchrony of both ventricles as well happening at the same time because you don't have that impulse going down the bundles of His. So this is usually considered a lethal rhythm. It's a pre-arrest rhythm. And if needed, you would initiate the bradycardia management and call a code because, again, this patient's cardiac output is going to be very significantly dropped. This is called an accelerated idioventricular because it exceeds the inherent rate of the ventricular pacemaker. An AIVR is usually going to run at a rate of 50 to 100. And again, there's no P waves, the R to R is regular, and it is very wide QRS. The rate 50 to 100, there are no P waves, so you can't measure a PRI. The QRS is very wide, usually greater than 0.12, and the QT usually is normal for the heart rate. And again, remember your QRSs are in the opposite directions of your T waves when you have ventricular rhythms. Also know that AVR may not trigger your monitor rate alarm because it is usually within the normal heart rate settings. However, it may show up as a change in your rhythm on your monitor. The causes is usually related to an increase in automaticity of the ventricles. Patients are usually asymptomatic. This is usually a transient rhythm, and so we don't want to suppress it. So it's usually a common brief perfusion rhythm after an MI. Oftentimes you may see it with digitoxicity because of the increased vagal tone, electrolyte abnormalities, any type of change in your structure that can happen in a cardiomyopathy or congenital heart disease or any kind of myocarditis. But again, your loss of atrial kick is usually not significant impact on the cardiac output because your heart rate is fast enough to usually maintain a pretty good cardiac output. And your management, usually none, because it's usually transient. It usually will go away on its own. Ventricular tachycardia, there's two different types. We're going to talk about the monomorphic. And these ventricular beats are at a rate of 140 to 250. And you do not have P waves. Okay, so you have ventricular tachycardia, so you have no atrial rate. You just have a ventricular rate. The rhythm is usually regular. It's greater than 100. Oftentimes it's 140 to 250. You have no P waves, so you cannot do a PRI, and your QRS is greater than 0.12 seconds. And your QT is not measurable because all you see are just QRSs going across the board. And the challenge that people want to know is, how do I measure my QRS? Well, we're not real big sticklers on measuring a QRS, so obviously it's wide. And you wouldn't waste time to measure a QRS with a ventricular tachycardia because this is a life-threatening arrhythmia that you should be able to pick up by sight, and you would want to act quickly on checking your patient. This is called monomorphic because the complexes are all the same in shape and size pretty much, and they are called monomorphic, or one shape. Your common causes of VT is myocardial scarring from previous MIs. There's an increased or enhanced automaticity of a focused area within the ventricles. And again, all the previous reasons we described that causes PVCs can be causing VTach. And also know that the scar tissue after myocardium that cannot conduct electrical activity, so there is usually a re-entry circuit around the scar tissue that can result in VTach. Your treatment for VTach, again, primarily you want to vomit, get the patient's vital signs, check the patient. Patient assessment will determine the course of action for VTach, where you would review stable versus unstable patient conditions, so that would be the treatment. So if your patient is stable and they're in sustained VTach, we do consider this a life-threatening arrhythmia. They might be able to be stable at first, but they will probably progress if you don't do something. But if they are stable in monomorphic VTach, you can try drug therapy. You might want to get a 12 EKG, but you would give them an antiarrhythmic, and the most common is amiodarone. If the patient is unstable, so their blood pressure is low, they're diaphoretic, they're pale, they're having chest pain, shortness of breath, these patients are unstable and they need synchronized cardioversion very quickly. And they would probably have to be on a post-conversion antiarrhythmic, such as amiodarone. If it is a pulseless VTach, we treat it just like V-fib. Oftentimes, patients who are in cardiac arrest will have their first sign will be VTach, and it goes into V-fib. So therefore, if it is pulseless VTach, we treat it just like V-fib, so we will defibrillate, administer CPR, and then epinephrine and antiarrhythmic as necessary. Amiodarone is usually one of the first choices for ventricular dysrhythmias for stable VTach, pulseless VTach, and V-fib. And we use it for all, it works very well for ventricular arrhythmias. It can be used in some atrial arrhythmias such as AFib, but we use it mostly for our ventricular rhythms. The adverse reactions to amiodarone is that it does cause hypotension of bradycardia, and it can prolong the QT interval. So those are other things that take into consideration when giving amiodarone. The dosing of amiodarone, it's different for different indications. So if you have a stable ventricular tachycardia, you would give 150 milligrams IV, and you're going to dilute that in 100 milliliters of D5W over 10 minutes. You may repeat it if needed, and then followed with a maintenance infusion. If it is in a cardiac arrest, so if they're in Pulseless V Tach or V-fib, then you would give 300 milligrams IV push, and you can rebolus per ACLS protocol, which would be 150 at about 5 minutes. Lidocaine may also be considered as an alternative to amiodarone for V-fib or Pulseless V Tach, that in an unresponsive to CPR and defibrillation and vasopressor therapy. In Torsades de point, we call this a polymorphic VTach because you're seeing different points. It does not look all the same. Torsades de point is considered twisting of points. And if you were looking at this, you have a getting bigger, and it's almost like twisting. It looks almost, and again, this one's a little bit more as I'm tracing the, it's almost like a spiraling. So if you map that out, we have what we call a twisting of points. So this is Torsades de point or polymorphic VTach. It oftentimes is associated with a prolonged QT. So patients that would, present with low magnesium or prolonged QTs, they, like your alcoholics, then they can also easily go into Torsades. And sometimes you have patients who have congenital long QT syndrome that can also go into Torsades. Polymorphic VTach is an unstable, should be cardioverted because the machine may not should not be cardioverted because the machine may not sense the R waves on the irregular rhythm and therefore would not fire. So immediate defibrillation with higher energy than cardioversion. So the Defib energy level is recommended for if somebody is unstable. If they're stable, you can give them drug therapy and correct the electrolyte imbalance or underlying factors, such as if their magnesium is low, most commonly treated with magnesium. And again, if they're unstable, you're going to defibrillate. If they're pulseless, you're going to defibrillate as well. Magnesium is widely used for Torsades de point. And remember, Torsades de point is a life-threatening condition, rhythm. But again, there's no evidence that will show the improvement of outcomes for ACLS. You will probably have to defibrillate patients, but usually it's not receptive until you've corrected the underlying. There's also life-threatening arrhythmias associated with digitoxicity. So if you are going to give magnesium, you're going to give 1 to 2 grams diluted in 10 milliliters of D5W over 5 minutes and followed by an infusion. The adverse reactions of magnesium is it does cause hypotension and it can cause myocardial depression. In ventricular fibrillation or V-fib, this is a life-threatening arrhythmia and there is no pulse. There is no contraction or cardiac output. So again, there's a disorganized, chaotic electricity activity in the ventricles. It's causing the ventricles to just quiver and not contract. So you're going to see the ECG is going to show wavy, irregular baseline without QRSs. And if the fibrillatory waves are large, in this, such as in this slide, it was referring to a coarse V-fib and is more likely to respond to a defibrillation shock. The sooner you defibrillate, the better chance you have to convert somebody. So new onset of V-fib is usually coarse, and if the arrest is a primary cardiac event versus a patient who has been dying with corresponding hypoxia or acidosis, but normally they respond very quickly or very well to defibrillation if you catch V-fib and defibrillate with very quickly, as well as giving CPR. If the fibrillatory waves are small, it is referred to as a fine V-fib. This is more commonly seen in patients who have been experiencing V-fib for a longer period of time or who have had prolonged episodes of hypoxia and acidosis or electrolyte imbalances. It usually requires drug therapy and the reversal of precipitating conditions before it will respond to defibrillation. V-fib may occur spontaneously or be preceded by V-tach. An artifact can mimic V-fib, so always check your patient and troubleshoot to correct artifact to make sure. So you treat your patients, not your monitors. So always check your patient, check a pulse. So ventricular fibrillation usually is frequently preceded by PVCs or V-tach. Most common cause of death in acute MI or myocardial infarction. Other causes of V-fib is myocardial ischemia, hypoxia, electrolyte imbalances, use of illegal drugs, a cardiomyopathy, or a congenital heart disease, coronary artery disease, and a myocarditis. May occur during anesthesia or during insertion of intracardiac catheters or following accidental electrocution. So if somebody electrically gets electrocuted by accident, that can stop their heart. With V-fib, death is imminent unless V-fib is recognized and treated immediately. So your treatment is, if you see fib, defib. V-fib, defib. You need to rapidly assess the CAB, circulation, airway, breathing, call a code. CPR should be started if the defibrillator is not immediately available. Once the defibrillator is there, no matter where they are in their cycle of CPR, you need to defibrillate as soon as possible. The first shock should be delivered within 3 to 5 minutes of onset for best survival outcomes. After the initial shock, continue with CPR, and then we're going to start thinking of some drug therapies. So CPR for 2 minutes or 5 cycles. Throughout the code, fresh hands on the chest every 2 minutes, and assess quality. If you have the feedback systems in your monitors, it's always good to monitor how well people are doing CPR or check for a pulse to make sure that they're perfusion. After 2 minutes, if it's still V-fib, you want to defib, and then resume CPR. Again, you're going to check every 2 minutes of the rhythm check to see if they're still in V-fib. After the second shock, you can try epinephrine, and that would be 1 milligram IV every 3 to 5 minutes. Now, epinephrine does not convert V-fib. It supports the CPR that you're giving. What defibrillation does is it stops the chaos of all the electrical going on in the ventricles. So when it stops the chaos, what the goal is that it will reset the SA node so that normal conduction will take over again. But epinephrine is given. You wouldn't want to give epinephrine after the first shock, because if you were able to successfully convert the person, you wouldn't want to have epinephrine in the system. That would potentially increase heart rate and increase myocardial ischemia, because the heart would become tachycardic. After your epinephrine and CPR for another 2 minutes, if it's still in V-fib, you would defib, and then you would want to consider an antiarrhythmic, usually amiodarone. After the first 3 shocks has been administered, then you would give Amiodarone 300. Remember to always give meds during CPR and minimize interruption in CPR to 10 seconds or less. So epinephrine is given for any pulseless rhythm, and its dose is 1 milligram IV push every 3 to 5 minutes IV or IO. What it does, it's a sympathetic mimicking, so it increases heart rate, it increases myocardial contractility, it increases myocardial oxygen demand, it increases automaticity. But primarily, in a code situation, it improves coronary and cerebral blood flow because it causes vasoconstriction, and therefore would increase perfusion pressure and basically help the CPR that is given. So you're giving good CPR and you're perfusing, but you need to vasoconstrict those blood vessels to help with forward flow and better perfusion. So epinephrine is basically supporting CPR, good CPR. Energy requirements for your defibrillation will vary. So oftentimes you'll see biphasic defibrillators being used, and they go up to about 200 joules. There might be other biphasic monitors out there or defibrillators that go up to 360 joules. Oftentimes some cardiologists would prefer to use those, because if you have somebody that has a really severe cardiomyopathy or a myocardium that does not respond as well, so they may want to have a higher level of energy to deliver. One of the key things to remember whenever you defibrillate is you always practice electrical safety. When you have to defibrillate somebody, whether you're synchronized cardioverting or if you are defibrillating somebody, you always make sure that you clear the patient, the bed, and the personnel before you deliver that shock. You would visually and verbally clear the patient. You don't just press the button and say clear. You say clear, you look to make sure nobody's touching the patient, and then you press the button. If you deliver that shock and somebody is touching the bed of where the patient is on, that electricity can travel through the patient, through the bed, and to the other person until it hits ground. And unfortunately, what it can do is it can injure the person, or it can stop their heart, because again, what you're doing is you're stopping the heart and resetting it. So always practice electrical safety when defibrillating. With asystole or ventricular standstill, you have the top strip is a ventricular standstill, which shows only P waves. Again, you treat it just like asystole. There is no pulse because you don't have any QRSs, and that's where your cardiac output comes from. And this can require from like a second degree type 2 or a complete heart block can progress to ventricular standstill. It is a cardiac arrest. And in the bottom one, there's no P's and basically absence of any ventricular activity except for this agonal beat, but this pretty much is also asystole. And again, there's no QRSs and there's no cardiac output. Asystole, we usually consider it a straight line, and it is a terminal rhythm following VT or V-fib or IVR, but what you're going to see is, again, it won't be as straight sometimes. It might have a little bit of a tiny baseline of some squigglies, so just be aware that asystole, again, you always want to check in 2 leads, because you could potentially have a fine V-fib in another lead that looks, gives you a better look at that rhythm. So it is a terminal rhythm, and usually the causes are metabolic acidosis or hypoxia or hyperkalemia or hypokalemia or hypothermia or overdose. We'll talk about your H's and T's in a little bit. And again, once you're in asystole, the only way that you're potentially going to reverse it, if you can reverse one of the causes of it. And you only have a 1 to 2% survival rate once a patient is in asystole or ventricular standstill. So your treatment is rapid CABs, check circulation, airway, breathing, check the monitor lead, verifying a second lead. You always want to start your CPR. You're going to make sure that they have airway management, IV access. You potentially will have to intubate the patient, especially if hypoxia is the cause of it. Usually your asystole is refractory to treatment unless you can reverse the cause of it. So look for the reversible causes. And again, you're going to give epinephrine 1 milligram every 3 to 5 minutes to support the CPR given. So pulseless electrical activity. So it's not really a picture to show you, except that PEA can have a normal complex of ECG complex, but the problem is there is no pulse. So you have no detectable pulse in the presence of an ECG tracing that would normally produce a pulse. So the cells are being told to depolarize, but this muscle cannot mechanically contract. So something is preventing, and we'll talk about the causes. So the heart is not pumping. So you always treat your patient, not the monitor. So always check to see if there is a pulse. So electrical activity with no mechanical response. Pulseless electrical activity, it used to be called EMD, electrical mechanical dissociation. So there was electricity, but there was no mechanical, meaning there was no pulse. So survival of your PEA depends on prompt recognition and treatment of underlying cause. So your H's and T's, Huff mentions hypoglycemia as a cause of PEA, but it's not in ACLS guidelines, but it's not something that you can't rule out. So your H's are your hypovolemia, hypoxia, hydrogen ion, such as in a metabolic acidosis, hyper or hypokalemia, hypothermia, tamponade, cardiac tamponade, tablets such as or toxins, tension pneumothorax, a thrombus such as in a PE or MI. So this is where your H's and T's. And your treatment of PEA is P, produce a pulse, E, administer epinephrine, A, assess your H's and T's. So in order to reverse PEA, you have to try to reverse the cause of it. So if they're hypovolemic, you're going to give them volume. If they're hypoxic, you're going to intubate. If they've got a hydrogen ion, such as in a metabolic acidosis, you're going to give good CPR and you're going to administer bicarb. If it's hyper or hypokalemia, you may have to give bicarb for the hyperkalemia. Hypothermia, you're going to warm them up. You may have to do a cardiac tamponade. There was paracentesis, and then you may have to do, if you know what they took for toxins or tablets, you might be able to give a reversal agent. Tension pneumothorax, you may have to put a chest tube. Again, you may not be able to reverse the pulmonary embolism if it's that severe that they gave cardiac collapse. But, and again, if it's a MI, if they're not alive, you can't do a cath or do a catheterization until you actually have a heartbeat back. But these are the causes, and if you could potentially find a reversible cause, that would be the best way to treat PEA. And so the significance is there's no cardiac output because there's no perfusion and no myocardial oxygen supply. And if unable to identify a correct underlying cause, resuscitation efforts will be unsuccessful. So rapid CAB assessment, CPR, IV, intubate, give epinephrine 1 milligram every 3 to 5 minutes, and identify the treatment. So like I said, P, produce CPR, E, and assess your causes with your H's and T's. If you can remember the name PEA and what the treatment would be. So in summary, ventricular beats are not preceded by a P wave. It does not go up into the atrium. You have a wide QRS, greater than or equal to 0.12 or more. The T waves are in the opposite direction of the QRS. Ventricular beats, when your rate is less than 40, it's an idioventricular rhythm. If your rate is 50 to 100, you have an accelerated idioventricular rhythm. If your rate is greater than 100, probably between 150 or 140 to 250, that would be ventricular tachycardia. If it is a premature beat and it's wide, it's a PVC. If it's a late beat, then it's a ventricular escape beat. Life-threatening rhythms, your V-fib, Pulseless V Tach, Asystole, and PEA. Again, PEA is going to be, and the ECG may be any rhythm, but there's no pulse. And PEA and asystole are treated the same. Pulse, epi, assess your H's and T's. So at this time, I'm going to have you do your practice strips. So pause the video, do your practice strips, and then when you come back, we'll do the review of them. And we have a scenario in the first rhythm strip. In this rhythm in 9:14, this is the one that says Mrs. Q's monitor alarm goes off. You find him losing consciousness, blood pressure 70/50. All right, so looking at the rhythm, you really shouldn't have to try to bring out your calipers or try to figure out what the rhythm is, but we will. We'll kind of fast forward that. But the rhythm is regular. The heart rate is about 214. Again, when you're looking at between R to R's, counting how many boxes, and then going to your conversion table in the back. Not that you would be doing that because this patient is unstable, so you want to act quickly. There's no P waves, you don't do PRI, your QRS is wide, probably about 4 boxes. Again, you wouldn't be taking the time to measure that. You can't really do a QT, so we're going to call this, it's wide, it's over 100, so we are in VTach. So this is unstable VTach. So your treatment would be synchronized cardioversion. So when you put somebody at synchronized cardioversion, just like SVT, this patient, you might want to consider sedating because it hurts, and you would put them on a monitor, you turn it to the V-fib mode, or Defib mode, excuse me, and then you hit the sync button. The sync button comes up, and what you're going to see is marks on your R waves. It's going to identify where your R waves, whether it's a dot or an arrow, but it's going to go mark all of the R waves across the, you get the idea. So it would mark all of the R waves, and it would say sync. It's very important to make sure that you sync with a pulse. You only sync with a pulse. This patient has a pulse. They have a blood pressure, so therefore they have a pulse. Even though their blood pressure is not great, they still have a pulse. So you always sync with a pulse. So when you synchronize cardiovert, what you're doing is you're delivering that energy, and it identifies where the R wave is. Always make sure that when you before you deliver the shock, you always clear the patient and make sure that you use safe electrical safety. Hit the button because you have your pads on, and hold the button down until it delivers, because again, it's not like Defib where you hit the button and it delivers. You have to hold the button down. It might take an extra half a second to identify where the R wave, so that will come in a safe place, so it doesn't hit the R on T and cause the patient to go into V-fib. So that's why you always use sync when your patient has a pulse, because you don't want to make the rhythm worse. You want to hopefully convert the rhythm. So this is unstable VTach, and we are going to synchronize cardiovert. In this rhythm, again, there's no QRSs, no P waves, so this is chaotic. We are in V-fib. It looks coarse V-fib. So what are we going to do? We're going to check CAB, and if they're pulseless, you're going to call for a code. You're going to start CPR. You're going to get a defibrillator as soon as or somebody's going to bring a defibrillator, hopefully. As soon as the defibrillator comes, you're going to stop CPR and defibrillate as fast as you can, and then resume CPR. After 2 minutes, you're going to check again. If they're still in V-fib, you're going to defibrillate again. At this time, you can administer 1 milligram of epinephrine. And after 2 minutes, if it's still in V-fib, you're going to defib again and resume CPR. And then you can consider amiodarone 300 milligrams IV push for a cardiac arrest. And you can give epinephrine every 3 minutes. Again, every time you check, if you're still in V-fib, you're going to defib. And good CPR. And page 921. So this rhythm, it's saying it's off by, it's irregular, but maybe it's off by 3 boxes. So, but the rate is 40 if you do the 6 seconds. So I'm checking how many R waves I have. So there's 4. There's no P waves, so I can't do a PRI. The QRS is wide. If you wanted to measure, it looks like, I would say probably around here. It looks like about 4 boxes, even 5 boxes, so 0.16 to 0.20. The QT interval, if you did measure, it is long. It looks like about 12 boxes or so, 0.48. The rhythm is slow and it's coming from the ventricles, so this is called idioventricular rhythm. So this is IVR. So your treatment would be always check your patient, get your vital signs. If the patient is symptomatic, then you would follow the Brady algorithm. And this one, this patient has basic rhythm is regular, and then it has PVCs, but the underlying rhythm is at a rate of 72. You do have P waves for your sinus beats, but you do not have P waves for your PVCs. Your PR interval, if you're measuring your PR interval, you're measuring before the P, before the QRS, and that looks like it's about 3 boxes or so. So it's 0.12. Your QRS of your normal beats looks like about 2 boxes. If you were to measure before your, I would say it's probably more like 4 boxes, 3 to 4 boxes of your PVCs. Your QT interval, and that looks like about 9, so 0.36, 0.38 maybe. All right, let's interpret this rhythm. So we have normal sinus rhythm because you have P waves, so we call them sinus. You do have premature beats. Again, your PAC would be narrow QRSs with a P wave. PJC would be a narrow QRS with an inverted P wave or no P wave. These premature beats are wide, and the QRSs are in the opposite direction of the T wave, so therefore they are PVCs. They are happening every 4th beat in this strip, so you can call it a quadrageminy, and the PVCs look the same. So there's more than one PVC and they look the same, so we call them unifocal PVCs coming in at quadrageminy. So you've completed the ventricular rhythms, so you will do your homework for your AV blocks and your ventricular rhythms, and then the next time you come on, we'll review the AV blocks homework and the pacemakers after you've completed that lecture as well. And thank you very much.